much again for the invitation regarding your congress. I'm pleased to talk about the role of laparoscopy in the field of advanced ovarian cancer, as it is mainly a big debate at the moment about how we should use it. Laparoscopy can be used as a tool for exploration and as a screening, or using laparoscopy as a surgical approach for the bulk. Using laparoscopy as a screening is about the question whether a patient is resectable or not resectable. There is now a new terminology for cytoreduction in advanced ovarian cancer, and the goal of primary cytoreductive surgery for the treatment of advanced ovarian disease is to achieve true microscopic disease. And now the term of optimal surgery should be avoided and replaced by complete resection and not optimal or suboptimal surgery. This comes from new publications, and it demonstrated that when you remove less than 10 millimeter disease or suboptimal disease, it's almost the same it's almost the same results, and the only goal that we should achieve is complete resection. So how can we assess tumor resectability? We can do it by clinical exam, age, and also to see whether the patient is keen for having extensive surgery. Biology with CA125 doesn't give any information. What gives information is radiology and, of course, laparoscopy. The role of CT to determine whether we are able to remove the disease inside the abdominal cavity is not exactly what we can expect to be sure that the disease is resectable or not resectable. And I like these two pictures because on the left you have small deposits around the liver, and on the right you have massive deposits around the liver. So many people would say that on the right is unresectable and on the left is resectable. And in fact, for those patients was exactly the opposite. The small disease on the left were unresectable because the confluence of the disease was complex, and on the right, the big deposit was easy to remove because the bigger are the deposits, the easier they are to remove. This is also another pitfall of the CT. For example, here the CT said, you have celiac disease, so it's unresectable, and as a surgical approach was easy to resect by only dissecting the celiac area. On the right, they said it's resectable, and in fact, when you look at this laparoscope, there was all those deposits on the guts, and for sure, when you have all those deposits around the guts, from the ileum, the jejunum, it's impossible to remove without removing all the small intestine, testes, and etc. So, laparoscopy to assess resectability is quite an interesting tool. And it's really interesting in order to see whether the small bowel is involved and how much of the bowel is involved. It's interesting for the anterior part of the diaphragm, but it's very difficult for the lesser sac and also for the portal vein to determine whether it's involved or not involved. So it's not a perfect. The most important thing is to make a surgical anatomy of the disease and to use the PCI as probably what is the most accepted around the world, actually. The PCI that you may discover with the scope is almost the same as the PCI of a laparotomy for a certain area of the disease. Small bowel, as I said, momentum for sure, pelvis, anterior part of the diaphragm, and abdominal and parietocolumnar. You can expect from the laparoscopy that what you see on laparoscopy is almost the same as what you could observe with laparotomy. But on the opposite, when you have a mental cake with no view of the small bowel, or when you have disease on the posterior aspect of the diaphragm, posterior aspect of the porta, lesser sac, and celiac trunk, you will not be able to see appropriately by the laparoscope if there is disease over there. And this is classical picture where the disease cannot be shown with a laparoscope through the umbilicus. It's behind the liver here, it's on the celiac trunk, it's behind the liver here, and it's here on the porta. So beware. What you see with an umbilical laparoscope is the external part of an iceberg. So you must be careful when using a laparoscope to decide if you go for laparotomy, or when you decide that, oh, it's impossible. It has huge implications for the patient. This is a nice example of what I'm talking about. This patient had, by laparoscopy, a simple nodule. But in fact, by mobilizing the liver, you can see on the right that she had huge disease behind the liver. So this was resectable for sure. But the disease you could see with the laparoscope, thinking that you remove everything with the laparoscope, well, there was disease behind the liver. There has been many publications now, and I just want to focus on one or two publications about the use of laparoscope for assess resectability. I think a nice one was the one of Fagotti, that is the reference. We use also this tool for HIPEC in colorectal patients, and it works as well. So the strategy should or could be that when you have a doubt about tumor resectability with CT, why don't performing a laparoscopy? If the laparoscopy said, no problem, you can resect it, then go for primary debulking surgery. If the laparoscopy said, it's good information that this patient is absolutely unresectable to no residual disease, then it's better probably to start with chemotherapy, neoadjuvant chemotherapy. Using laparoscopy as a surgical approach for debulking. Well, this is easy. As a primary debulking, look at this publication in May 2017. This is an interesting publication, and I think the main publication in this area. And they look about National Cancer Database to identify a cohort of patients diagnosed with stage 3C4 epithelial ovarian cancer between 2010 and 2012. So they could identify over 3,000 patients, about 450 patients who underwent surgery by laparoscopy. And then they showed that survival did not differ after adjustment for demographic characteristics, facility type, presence of comorbidity, and stage between the two groups. We'll talk about it later. So they said, in conclusion, that ovarian cancer patients selected for laparoscopic interval debulking surgery after neoadjuvant therapy have 3-year survival rates similar to women who undergo interval debulking by laparotomy. This is really strange because when we talk about stage, using FIGO stage, we have to question a big problem. These are three fruits, banana, an apple, and a strawberry. They are both fruits. And those are stage 3C. All 3C disease, more than 2 centimeter disease, but on the left, this could be really easy. In the middle, a bit challenging, and on the right, unacceptable to remove because you have infiltration of the muscle. You must remove all the muscle of the diaphragm. This is not acceptable surgery for a patient presenting ovarian carcinoma. So, claiming that because of stage, comparable stage, you should compare apple and strawberry, this is absolutely unuseful. This publication doesn't give you any information about if we should or not use laparoscopy instead of laparotomy for advanced ovarian disease. The goal of surgery in advanced ovarian carcinoma, I told you, is to remove every disease. And this is what happens for people like us who are doing every week some ovarian cancer case. Sometimes we open and somebody that is not used to surgery will say, wow, this is unresectable, what are you doing there? But in fact, when you know this type of surgery, you know that spending some time by using some technique, the Hudson technique and another technique, the goal is to remove all the disease in the pelvis. And saying sometimes that the pelvis is unresectable is some kind of unacceptable affirmation concerning ovarian cancer patients. Retroperitoneal area also is important, and you know that when there are big bulky nodes, you have to remove the nodes, whatever it costs. And there are also some quality control issues really important when you talk about complete debulking and complete hormonectomy. How many does complete hormonectomy? Which means that you remove absolutely all the omentum from the right to the left, and even by removing the lower part of the gastrosplenic ligament. How many does that? And should we do that by laparoscopy when you have advanced disease? Come on, it's not serious. Also, there are some quality control regarding resectability consideration by laparoscopy and laparotomy. These are examples of patients declaring or being unresectable for the porta, and in fact, when you remove closely the gallbladder and you dissect all the porta, you can remove those diseases. Another area where people are not keen to do is around the liver, when you have scalloping of the liver, and it's just a matter of time and experience. So at the end of the surgery, it's what like it should look when you do advanced disease, that you remove all the peritoneum everywhere there is some disease. And honestly, doing this type of surgery by laparoscopy, for me, it's just unacceptable. It's just another world. So doing laparoscopy, why not for small deposits somewhere? But when you have normal advanced disease, it's impossible. And surgical oncology consideration and anatomy is also the small bowel, I told you before. The length of resection, how much length is it acceptable to remove, and quality of life issue for the patient as well. Using laparoscopy for debulking as interval. Well, this is a more interesting question, because the reality in our country, for example, is that in apparently expert center, 50 to 70% of the patients are treated by neoadjuvant chemotherapy, even in expert cancer center. Why? Well, some of the patients has been decided in cancer center that we go for neoadjuvant, but a lot of patients have been referred to cancer center after they received neoadjuvant chemotherapy. So the reality is that close to half, or more than half of the patients receive neoadjuvant chemotherapy. And what is really interesting, and you know, everybody experienced that, a lot of patients who receive neoadjuvant chemotherapy has no more disease after 3 cycles. Everything is clean. So should we perform a big, large, middle laparotomy in a patient that has no more disease? That is a big question. And say, well, I'm a big surgeon, big incision, so let's go for it. When you have no more disease, well, this is maybe a good place for laparoscopy. Just to remove the omentum, remove uterus, both ovaries, and we talked yesterday, remember, about the nodes. When you have normal nodes after neoadjuvant chemotherapy, what about the use of doing a lymphadenectomy? No use for that. So there is subsequently a little group of patients that may be eligible for laparoscopy. And this is the field where we need some data, and there are a lack of that. Also, there are new arms in gynecological cancer treatment, very hopefully. PARP inhibitors, advance of immunotherapy, and will be biology in the tumor influence the surgical strategy from 2017, 18 to 20, 21, 22. Look at all those recent studies, the ASCO 2015, using the PARP inhibitors as first instance, using other pathway like the WEE1 inhibitor, showing some maybe interesting difference in survival. Also, you know that there are selected patients eligible for targeted therapy, the CD31 pathway, new phase 1, 2 studies using anti-PD1, PD-L1 that are immunomodulator. Also, some tumor may favor the use of neoadjuvant chemotherapy and some other upfront surgery when you have a doubt whether you should go for surgery or no surgery. For example, high-grade serous are extremely sensitive to chemotherapy. Shall we always, like tourists, go for it and go for surgery? And low-grade